Jeffrey Weiss. While I'm introducing our speakers for today, if the speakers don't mind putting up their slides again so that we could see it. Also, if you can hear me, Mike or Reed, please speak up to make sure you can hear us properly. Hello? Oh boy. They permanently put themselves on mute. All right, so I'm going to just proceed with the introduction of our speakers. Today, we are very fortunate to have two speakers, Mr. Vreeland and Mr. Mike Selick. Mr. Vreeland is a Director of Policy at Housing Works and was a co-organizer of the New York State Hepatitis C Elimination Summit held on February 7th, 2017. He is joined by Mr. Mike Selick, who coordinates the Harm Reduction Coalition's policy and capacity building work focusing on hepatitis C. Mr. Selick has been a community organizer and advocate for human rights focusing on police accountability, inequity, drug use, sex work, homelessness, HIV, and hepatitis C for more than a decade. Prior to joining the organization, he worked at New York City harm reduction programs for 4 years, first with a focus on public policy and peer training, and then as the Syringe Exchange Program Manager. He currently serves on the board of the PROS network, which works to improve the health and rights of people engaging in the sex trade. He earned his Master of Social Work with a concentration in public policy from Columbia University, where he is currently an adjunct teaching new social workers about advocacy and harm reduction. Some brief housekeeping notes before we get started with the presentation at hand. Mr. Vreeland and Mr. Selick will be taking questions at the end of the webinar. Please hold your questions until then. We will unmute the lines and open the session up for discussion at the end. At the end, there will also be a brief survey that will pop up asking for your feedback regarding our webinar series. We would greatly appreciate it if you would take the time to fill it out, as the results will help us ensure what we continue to bring to you is high quality and relevant. Again, I'm requesting Mr. Vreeland and Mr. Selick, if you hear us, please speak up.
Yes, can you hear us?
Excellent, and I see that you're putting up your slides, yay.
Yeah, sorry everybody. Of course, the internet in our room that we have specifically for webinars went down with 1 minute before the webinar started, so we had to think fast. We're here, and you all see our slides now?
Yes, perfect.
Good.
You can get started.
Excellent. So welcome to the webinar. This is my name is Reed Vreeland, Director of Policy at Housing Works, and we also have
Mike Selick. I'm the Hepatitis C Program Coordinator at the Harm Reduction Coalition.
And today's webinar is on the New York State Hepatitis C elimination work, specifically going from the vision we have to the reality of what it will take to eliminate hepatitis C in New York State.
So thank you to HepCure for hosting this webinar and asking us to speak. I'm going to start off by talking a little bit about our organizations for a minute, and then we're going to go through the history of this process, and we're going to try to wrap this up in 45 minutes or less so that we have at least 15 minutes for questions and answers at the end. So let's get started. The Harm Reduction Coalition was founded in 1993 by needle exchange providers, advocates, drug users, and more. We are a national coalition that does policy and advocacy work, training and capacity building, overdose prevention. We have a biannual national conference, and we make resources and publications that you can find on our website, harmreduction.org.
And Housing Works is a healing community of people living with and affected by HIV/AIDS. Our mission is to end the dual crises of AIDS and homelessness. We provide direct healthcare services, housing, medical and behavioral care, job training, and harm reduction services.
So, quick review of our agenda for today. First, we're going to go through an overview of New York State. That's what NYS stands for, New York State, and NYC of New York City, hepatitis C epidemic. Part 2 we're going to talk about is whether or not hepatitis C elimination is even feasible. Part 3 we're going to talk about establishing New York State Hep C elimination targets. Part 4 is consensus statement on HCV elimination in New York State, and we'll talk through Part 5 is recommendations from work groups, and then we have a call to action and questions and answers at the end. So we're going to get started off with talking about some of the history of this process.
Great. So between spring of 2016 and February of 2017, we established a broad group of over 94 different New York State stakeholders, and this included epidemiologists, physicians, harm reduction and social service providers, and community advocates. And we all work together to build consensus on whether it is possible to eliminate Hep C in New York State and what it will take to do so. We did partner with the New York City and State Department of Health in this project and had a considerable amount of technical support from the city and state, and some of the epi data we're going to present are from the city and state. So this group, during this period of time, was able to do 3 concrete things. One, we put together a New York State Hepatitis C Elimination Summit on February 7th. We split into 5 different work groups and advanced 30 recommendations that can inform a New York State plan to eliminate Hep C. So these recommendations are really going to be, we hope, a jumping off point for a plan to eliminate Hep C. And then we created a consensus document on hepatitis C elimination in New York State. This document was signed by over 119 organizations and delivered to Governor Cuomo, the Speaker of the Assembly, and the Senate Majority Leader. And this happened a month after the summit, so on March 8th.
All right, so now we're going to talk briefly about some of the epidemiological data for the state of New York. So since 2001, more than 250,200 chronic cases of HCV have been reported in New York State. In 2014, there were 16,169 chronic HCV cases and 127 acute cases reported. Although NYC has historically been the epicenter of the state's HCV epidemic, in 2014, more than half of new chronic hepatitis C cases were diagnosed outside of the city. Since 2004, in New York State, there's been a shift in age distribution of reported HCV cases from being primarily among persons ages 40 to 60, meaning the baby boomers, to being reported among a growing second cohort of persons aged 20 to 40. This shift is especially striking outside of NYC, as we'll see on the next couple slides. There's also been a shift in the distribution of cases by sex. In 2004, females accounted for 31.9% of HCV cases reported outside of the city. This proportion increased to 38.2% in 2014. So if you look at these 3 graphs you have in front of us, this shows the rise in Hep C among young people, and particularly young people who inject drugs. So in 2005, this is a baby boomer issue. You see all of the spikes in the middle areas between 42 and 60, but then when you look over to 2015, it becomes the young people who inject drugs issue as well as a baby boomer issue. So there's a big spike around the 18 to 36 range, and then another big spike from 48 to 72 for the baby boomers. So that's what we're trying to show on with these charts. So this next slide shows how injection drug use is related to transmission. The young people here, we believe, are young people who are injecting drugs. So that's the graph on the left. The graph on the right, it's a little bit, that's the graph on the right. On the graph on the left, you can see the bigger baby boomer numbers, a little bit lower in the young people who inject drugs, but still definitely a lot of that only a couple years ago in 2012. For baby boomers, it's a little unclear. Most of the transmissions are unknown because we did not know about hepatitis C in that generation. And this is a map of New York State. And the point here is to show that this is a statewide epidemic. It's not just New York City. It's not just in one particular area. The graph has hotspots, the map has hotspots in various regions. So this is just a chart of some of the regions that are seeing increases in reported cases. They're basically increases everywhere, but they're much less pronounced. If you look at the greenish one, that's at 3% since 2012, that's metropolitan, as opposed to more upstate and western New York in the capital region, which is around Albany. So just an overview of the New York City Hep C epidemic. We estimate that 146,500 people are living with chronic HCV in New York City. In 2015, 7,328 newly reported people tested positive for HCV. Preliminary 2016 data shows almost 12,000 newly reported persons, 55% being males, 43% being in the baby boomer generation. So changing kids definition accounts for large increases across all ages. There's also been some more enhanced surveillance that's been happening since 2009 to 2012. We're finding pretty equal distribution between 30% Hispanics, 30% Blacks, almost 40% injection drug use, and 36% are reporting intranasal drug use, and 51% were born in the U.S. or Puerto Rico. And 15% of people, which is over 23,000, have been reported to DOHMH with HIV/AIDS, also known to have current hepatitis C. So there's a large number of people who both co-infected with Hep C and HIV. And this is a map of New York City, all the boroughs. With this map, you can see where the zip codes are that have the higher levels of Hep C rates in the city. An interesting note is the Upper West Side zip codes are having higher numbers. That's like zip code 1001 and 10018, and this is where the main post office is, where many homeless people get their mail. And there's also a homeless healthcare center in that neighborhood. So that accounts for why there's such higher levels there than you might expect. Also, Rikers Island is our local jail, which has the highest numbers and highest rates in the city. And finally, on data, this is our care cascade for prevalent infections. You can see the large total numbers, then a quick drop off to people who are aware of infection, and then we're down to only 14% who are actually cured. I do think 14% is a huge victory. I don't think we see that in a lot of other states, but 14% is not eliminating hepatitis C at this time. So now Reed's going to take over and talk a little bit about, is it even feasible for us to eliminate hepatitis C in New York State? The answer is yes.
Thanks, Mike. So I'm going to go over really, we just got a preview of where we are now. What is feasible going forward to eliminate Hep C? We, as a committee of over 96 providers, believe that it is indeed feasible. This is supported by the National Academy's report. 90% of HCV infections are curable, and 80% are preventable. So that really shows if 90% are curable and 80% are preventable, this really is an epidemic that we can eliminate. We can get to elimination. But what will it take to get to elimination? This chart shows both the feasibility, but also some of the barriers to achieving elimination. Poor HCV surveillance is one of the barriers. Only about half of people infected with HCV know their status, know their hepatitis C status. So in statewide, that number is about 50% of people who are Hep C positive don't know their status. And in New York City, it's about that 60% of people do know their status. So the city seems to be doing a bit better than the state in terms of connecting people to testing. Most new Hep C infection is associated with injection drug use, and it can be difficult to screen, connect to care. One of the biggest things that we're seeing is Hep C stigma and miseducation about past treatments. So some people may have been tested at an earlier stage with interferon-based treatments for the only option, and so they associate treatment with the interferon regimen and haven't been educated about the new generation of Hep C regimens. Stigma is an ongoing barrier, and the biggest, perhaps, is that Hep C has not been a public health priority. So other jurisdictions have been able to set Hep C elimination targets. Cherokee Nation, the country of Georgia, not the state, World Health Organization, and the state of Rhode Island. Some of the examples on the slide show what targets were set. And what is a goal versus target? I think that's kind of an important thing to go over when we're discussing elimination. So a goal is time-bound realization of a vision or end state. So the elimination of the hepatitis C epidemic by 2030 would be a goal. The target would be specifically getting to 90% reduction or a specific percentage of reduction of new cases, and a specific percentage of cure, and then how many people to be treated per year. And then the metric is the ongoing measurement and monitoring of success. So making sure that we are tracking where we are on the care continuum for hepatitis C at each stage of the care continuum, and establishing interim targets between now and the end year goal to make sure we're on track to eliminate the hepatitis C epidemic. Here's an example of a projection of the Rhode Island hepatitis C elimination scenario. This graph really shows what their targets are. The lower line shows their targets versus what will occur if nothing happens. And it also illustrates the difference in burden that we can achieve by implementing an elimination plan. This slide shows the WHO targets on eliminating hepatitis B and C as public health threats. That's how they are referring to it. And specifically, they have targets around reduction of deaths and reduction of new cases. So how do we, what's next for New York State? A potential goal, this is not a goal that has been set, but it could be a potential goal, is a 90% reduction in chronic cases by 2030. For that slide when we talked about goals, one of the key elements, and I think one of the most important elements in a way, is the accountability part. So this is a goal that needs to be established with consensus with everybody at the table, both government, community, and providers, that something is achievable. And only then can we really set a final goal. And so we have that collective accountability. And once we establish that goal, it's extremely important to create numbers, to establish the number of people we need to treat annually to achieve that goal. This slide refers to some of what needs to happen in terms of the New York City surveillance data and New York State surveillance data to establish clear targets, identify all individuals with Hep C in New York State from 2000 to 2015, modify case lists for deaths and in and out migration from New York State, adjust for individuals no longer infected who have been cured or under diagnosis to get to proportion with HCV. So really making sure we're cleaning up the data before we establish these targets to make sure we're working with the best numbers possible. As I said before, when it comes to hepatitis C, we don't have the best surveillance data, and so it's important for us to do the work we can to have the clearest information when we're establishing these targets. Potential next steps for target setting. Went through this before, but update the HCV prevalence for New York State, confirm an elimination target, and this really has to be done in a task force setting or a setting with the authority to really make the commitment for the state and city, calculate a number to treat annually to meet the target, and whether that's 90% or another target.
This slide shows the statements on HCV elimination in New York State. There was a call to action. We got well over 100 organizations signed on to this consensus statement, and this is what we have developed so far. This and the recommendations we're about to go through out of the Hep C Summit process. So I'm not going to read this entire paragraph to you, but the important takeaways are we're calling for a task force and a joint commitment from the legislature, the governor, and industry partners in order for us to move forward. And these are the 5 community pillars of the HCV elimination that we established as a community to working on the HCV Elimination Summit.
So these 5 community pillars are extremely important, and we spent a lot of time during the process leading up to the summit making these very clear. So the first one is to enhance HCV prevention, testing, and linkage to care services for people who inject drugs, people who are incarcerated, men who have sex with men, and other populations disproportionately impacted by HCV infection. So if we think about that, the National Academy slide that we saw before, that 80% of new HCV infections are preventable, this is really what we're talking about. We need to enhance our prevention.
The second community pillar is expand HCV screening and testing to identify people living with HCV who are unaware of their status and link them to care. We currently believe that half or more of the people who are living with HCV in New York State do not know about their status and are not therefore linked to care.
Pillar 3 is provide access to clinically appropriate medical care and affordable hepatitis C treatment without restrictions, and ensure the availability of necessary supportive services for all New Yorkers living with hepatitis C infection.
The 4th pillar is to enhance New York State HCV surveillance, set and track HCV elimination targets, and make this information available to the public. We've said repeatedly throughout this that we do not have the best surveillance system for hepatitis C. So this pillar is to make sure that we improve our surveillance system and make sure that we track how we're actually reaching our targets so that we could keep on track and get to our goals.
And pillar 5 is to commit New York State government and elected officials, public health professionals, HCV experts, and industry partners to leadership and ownership of the New York State plan to eliminate hepatitis C, alongside community members living with and affected by hepatitis C. This was something extremely important that we emphasized during the summit, that people with and affected by and cured of hepatitis C need to be at the table and have meaningful involvement at every stage of a task force process.
So we created 5 different work groups. Each work group had a dozen or so people working on them: doctors, social workers, case managers, policy advocates, et cetera, people directly impacted. And from each of the work groups, there were multiple meetings, and through those meetings, we came up with a bunch of recommendations. So Reed and I are going to go through the 5 work groups' recommendations. We are not going to read them all for the sake of time. We are going to highlight the ones that we personally think are very interesting and important. That might not be what another presenter would choose, so we had a hard time picking our favorites because we think all of these are essential to ending the hepatitis C in New York State. So for prevention recommendations, I'm really excited about the opportunity to expand syringe exchange programming. We do have great syringe exchange programming in the state of New York, but it's not nearly enough. There's certainly a lack of coverage, particularly in the upstate and western New York. We have 15 programs in New York City, but even that isn't nearly enough for the city the size of New York City. So really would like to see that expanded. We also are very excited about the possibility of increasing availability of medication-assisted treatment for those addicted to heroin or opiates. Particularly excited about potentially having buprenorphine Suboxone treatments and having that through our syringe exchange and harm reduction programs. And finally, for prevention, having increased prevention, testing, and treatment in correctional facilities. This is really important. Correctional facilities is one of the locations where we see higher rates of hepatitis C, and there's not much happening as far as prevention, testing, and treatment. We have people, they're a captive audience. It's a good time to get people on treatment, get them cured, and give them the chance to move on with their lives.
So in terms of testing and linkage, expand patient and peer navigation programs. From the New York City perspective, we have a city hepatitis C peer program that's been very effective at screening people in our syringe exchange programs for hepatitis C and doing peer education on hep C. That isn't happening as much statewide, and those types of programs are very valuable. Create tools to improve surveillance and outbreak detection so that testing can be offered to those at risk and follow-up provided to those diagnosed with hepatitis C. Honestly, all of the items on this page are important. And I would also add that all of these are actually abbreviated versions of larger recommendations. And we did have a recommendation that also dealt with enforcing routine hep C testing, which I don't see listed here. So Mike's going to continue.
So the next was the Care and Treatment Access Group. So the recommendations that I want to highlight from here are all payer formulary restrictions for hepatitis C medication authorization that is not based on AASLD guidelines should be eliminated. Payers should always approve medications per evidence-based guidelines. So this one is referring to treatment restrictions, most of which have been removed in New York State as far as Medicaid is paying for most people's treatments and authorizing it, although they're often denying it at first and requiring people to do some advocacy to get those denials overturned. And the Attorney General of New York threatened to sue the 7 private insurers to make sure that they would also cover this. So things are definitely headed in the right direction right now. There's definitely more that needs to happen, but we would like to see nobody getting restrictions for their medications from the payers or from the doctors. And then the next one is that payers should expect a clear and consistent policy and full payment for hepatitis C medications. There should be increased transparency about negotiated drug costs for payers, because each company can negotiate their own drug pricing costs. There's no transparency, there's no clear and consistent policy, and a lot of the pharmacies are finding they're getting reimbursed very slowly or taking a long time for it. So we need to have people get treated who need the treatment. We need to have these drug costs come down, and we believe having negotiated prices in the open instead of in the shadows is the way to get us to there, and that would help lower a lot of the barriers to get people cured.
So I apologize if you do hear any background sound. We'll try to continue despite it. So there's surveillance recommendations. The first one refers to the target setting that I was discussing earlier. We need to strengthen surveillance systems in the statewide and across the state, making sure that counties also have support to do their reporting. Systematically track information and make it public. That's another really important goal. Establish sentinel surveillance programs to track HCV prevalence and incidence in populations where estimates based on reported cases are inadequate. So where we have gaps in surveillance data, to do the extra work. I want to give a plug to the HIV Ending the Epidemic ETE dashboard. It's a New York State Ending the Epidemic dashboard that was created out of the New York State plan. So that is an example of the type of public-facing tool that we can establish to track the progress of a hepatitis C elimination plan.
The final work group was the social determinants recommendations. We actually did not initially start off with this work group, but we thought it was such an important cross-cutting issue that we wanted to make sure we pulled it out and talked about it specifically rather than neglected to go into it. So I would like to highlight the eliminate legal barriers to HCV prevention services for people who inject drugs. So the first one says fully legalize syringe possession. In New York State, there is still a criminal code that makes syringe possession illegal both for new syringes and for used syringes. However, there is a carve-out in that law that says it's not illegal to possess a new syringe in the state of New York if you got it legally, meaning from a syringe exchange or pharmacy. We believe that criminal code needs to disappear. You should not be able to get charged with syringe possession in New York State when it's a new syringe. For used syringes, there's a drug charge that says drug possession in the 7th degree, essentially such a small quantity of drugs that they need a microscope to find it. So this is how people have been getting arrested for carrying used syringes in the state of New York. Now, the penal code says that drug possession in the 7th degree should not apply when the drug residue is found in a syringe that was obtained legally through a syringe exchange program or through a pharmacy. But we would like to get rid of that second part of the law that says legally through these pharmacies and just have it say, if the residue is in a syringe, you should not be getting arrested. The next bullet point under this actually goes back to that drug possession in the 7th degree charge. We would like to see that entire charge disappear anyway. We don't want people to get arrested for carrying any syringe, any non-syringe injection equipment. So any paraphernalia charges. We want people to be using cookers or clean cottons or any of the works that are given out at our syringe exchange sites to help prevent hepatitis C. We also would like to see authorization for supervised drug consumption services in the state of New York. And we just generally want to reduce criminal justice involvement for people who inject drugs. That's what PWID means, who are at risk of HCV infection. And finally, the last bullet here, improve HCV prevention, screen, and care for people with HCV who are incarcerated, and increase funding for discharge planning and care coordination services following release from a correctional setting. So what we're seeing happen here is, as I said earlier, there's no real care prevention for Hep C in prisons, and a lot of people who are incarcerated are getting infected while incarcerated or were infected beforehand. We're also seeing people who are being discharged while in the middle of treatment who don't have their Medicaid turned on so that they could continue treatment while getting out, don't have a referral to see a doctor. Once treatment has been initiated, we don't want to see that treatment stop in the middle. We want to make sure that there's care coordination so that when someone's released from prison, they are able to continue treatment and able to obtain SVR regardless of whether or not they're continued to be incarcerated.
And so this slide is the call to action moment. So there's real urgency and action that has been generated from the summit and from the consensus statement. This urgency and action, we hope, will do three things in the near term. One, get the state to negotiate with industry partners on Hep C treatment costs. Two, the appointment of a hepatitis C elimination task force. And three, lead to major new investments in Hep C prevention, testing, linkage to care, and treatment capacity and supportive services toward the goal of elimination of Hep C in New York State. But I emphasize that we really need to be taking action, and that means all of us, both everyone on the call on the webinar now, and all the people who've already been activated. It's going to take continued momentum and continued advocacy. I want to take a look at what we've been able to achieve with the New York State Ending the HIV Epidemic Plan. Even though we only 50% of people with hepatitis C know their status, for HIV, that number in the same state is at 93%. There's no reason there's no reason for us to, well, we know we can achieve the results if we have the resources to do it. We actually have a cure for hepatitis C, so we can improve and actually attain elimination targets if we have the resources to do so. So there are several concrete things I'm going to ask the participants on this webinar to do. One is to sign on to the New York State Hepatitis C Elimination Consensus Statement. It has already been delivered to the governor, but we would like to get additional sign-ons if possible. So we will be sending out a follow-up email to the webinar with information on how to sign on. And I encourage everyone to do so, even if you're not from New York State. Number two, work in your area to create hepatitis C either elimination plan in your jurisdiction if you're outside of New York State, or mobilization within your area of New York State. We know that it took scientists doing research in laboratories to make these hepatitis C cures possible, but now that they're possible, it's going to take real action and activism, and that means also engagement from the medical community and provider community to actually make these treatments now accessible to people who need them. You can't get treated if you don't know how you have hepatitis C, and you can't get treated if you can't afford treatment. I also urge people on the call to protect the ACA and Medicaid, and also a last point is to be part of the Vocal New York State Hepatitis C Elimination Campaign, and that is a group that is just now starting to come into being to take the vision of the consensus statement and work toward that as a goal. So I want to give some major acknowledgements in terms of to people who helped both with slides for this presentation and with the summit process. For New York City DOHMH, Angelica Bocour, Eric Rudy, Ann Winters, Kyle Falugi, really tremendous team at DOHMH, and a tremendous team at New York State Department of Health, AIDS Institute, Colleen Flanagan, Angie Maxted, Larissa Wilberscheid. And then in terms of national expertise, we drew on for this particular presentation, John Ward from CDC and Jillian Buckley from the National Academies. And of course, tremendous acknowledgement to Vocal New York, who hosted the Hepatitis C Elimination Summit, particularly Jeremy Saunders, Clifton Garman, and Angie Woody. And I also want to acknowledge all of the people who participated in the work groups to generate the work group recommendations. So you really see the breadth of expertise and the people who contributed time and sweat to this process. We really see the summit as the beginning point, not the end point, obviously, and we will continue to move this fight forward. This photo is from Vocal's Hepatitis C Legislative Awareness Day, which happened the day before the summit. Just wanted to end with a kind of a collective action call. Again, please sign the consensus statement, work in your area to create an HCV elimination plan or get involved with Vocal's elimination campaign, and do what you can to protect the ACA and Medicaid and other critical programs that will be necessary to help in the elimination process. So I think we'll open it up to questions.
Great, thank you so much, Reed and Mike. We're going to unmute the lines now for our listeners. I'd like to remind our listeners, if you don't intend on asking a question or making a comment, please mute line so we don't have background noise as much. Also, for our listeners who don't have a microphone or speakerphone at their desk, please type in the question. Make sure it's for the host. We are the host, and we'll be able to read it out for you. Sometimes if you to the presenter, they might not be able to see the comments. Submit to the host only, that would be great. And we're ready to take on questions. Anybody want to start it off? Anybody on the call that was involved in the summit want to share your experience? Well, okay, so I'll start off. I unfortunately was not able to make it to the summit on February 7th, but I did work with the Treatment and Access Committee to put together the recommendations. I have to say, I think it was one of the most well-organized, well-oiled machine that Dr. Weiss and I have had the pleasure and the honor of working with. I think it was a focused, concerted effort. Even though you had maybe more than 50 people involved, we still all worked together really well. And I want to give credit to all the leaders in the committees, but also to you, Reed and Mike, for organizing that.
Thank you. Can you still hear us?
We can hear you. Can you hear me?
Okay. Yeah, absolutely. So I would really love to hear from individuals who are on this webinar call. You know, usually when we do this kind of work, we're in a room where we can see each other. So even if you don't have a question, it would be great to just hear from everyone about where you are, what, and you know, how this might apply to your area. Or you're part of New York State. It's really an important part of the organizing part of this to be able to kind of see everyone in the room. So since we can't actually see everyone in the room on this webinar, I encourage people to use this time to introduce yourselves.
Yeah. We also have, so Reed and Mike, sometimes our listeners might not have access to a microphone or a speakerphone, so they have to type in their comments. And one of our listeners just did, Valsa has typed in, since Rikers Island has such a high rate, any efforts to eliminate hepatitis C there? Very good question.
Yeah, that's a great question. We had an excellent presentation at the summit from Dr. McDonald, the medical director at Rikers. We can actually provide those slides. They have been made public. Rikers, I was very impressed by some of the hepatitis C work they're doing. One of the challenges is the short stays that many people at Rikers have, which makes the full treatment regimen difficult to achieve. But I think that the presentation that was presented at the summit would be able to answer some of those questions, and I'd encourage others to look at that presentation, and if you are associated with corrections in other jurisdictions, Rikers could potentially be something to look at what they're doing there to replicate what's working, and then look at any remaining challenges.
And we are trying to, work on some policy work in both New York City and New York State levels to get more prevention, treatment, surveillance, et cetera, in prisons, so that both New York City and state policy work would include Rikers. And we've done good work trying to get navigators and peer navigators to be in touch with the Rikers medical directors, so that when they have a client that they know is going to be incarcerated, that their treatment can continue and that they could continue to provide supports. So I know for a fact at least some of the syringe exchange programs, HepCure have been able to work with participants in their programs who are in the middle of Hep C treatment and got arrested for whatever and are only going to be in lockup for a week or two, to get their pills to them and get them continued through treatment so that their treatment is not disrupted by their incarceration.
That's a great question to start off with. Does any of our listeners have other questions or comments, or just want to introduce yourself and allow us to get to know you and your role in the hepatitis C cascade?
I'll jump in. This is Jeff Weiss at Mount Sinai. Thank you both so much for the presentation. I think other states are really looking to New York State, really taken a lead in terms of organizing this type of elimination campaign. And obviously the goal is to get attention and dollars at the statewide level to achieve some of these goals. Could you say a little bit about the process of actually bringing this set of goals and these initiatives to the attention of policymakers, eventually the governor, and how that sort of process works in terms of trying to access funds for some of these initiatives? Because I think a lot of other states are looking to the work being done in New York State to sort of try to do similar types of things.
Thanks, Jeff. I think it's really important when doing this type of work to have consensus in the community and among medical providers. And that was really what we were able to achieve during the summit process. Now the next step is applying our collective advocacy forces on government officials and industry partners, the pharmaceutical companies in particular, to come to a deal on price in New York State to allow this type of initiative to be possible. We know that the state is not going to make the extra investments unless it can crunch the numbers and see that it is possible to actually eliminate hepatitis C without blowing through the Medicaid cap. And I have no doubt that this is one thing that we have been able to do. We've applied that pressure. I hope that we'll be able to see a really important next step of getting the state and industry partners together to create that deal that will then allow us to actually create a statewide elimination plan that has funding.
And we have had many years of history of hepatitis advocacy in New York City and state, and I think without that we wouldn't have been in a position to even start this conversation. So the advocates already have relationships with our city health department, our state health department. We've gone up to Albany in 2013. We passed the ever state testing bill for Hep C, so it mandates that doctors offer a test to anyone from the baby boomer birth cohort. So we had started funding budget advocacy this year in December, well before we had the summit ready to go, using the message that we're coming up with a plan to end Hep C, but we can't wait until that plan is ready to go. We need money now. We've been doing that advocacy for years, and we'll continue to do it, and that really gives us the basis where we have the relationships and the knowledge to get our policymakers on board. So if you're not starting off with that framework, I would say start small and pick a few reasonable goals, that something like a baby boomer testing law, and then set your sights a couple years from now where you've built up those relationships and are ready to start showing you could deliver and bring forth policies that make sense, and bring those up to your policymakers and show them that it can be done.
Thank you.
Great, thanks, Mike and Reed. I guess one last moment for our listeners to submit questions, comments. Well then, I guess Mike and Reed, before we wrap up, do you mind showing our listeners how they could sign on to the summit? Like how they could provide their support? You mentioned it a couple times in your presentation.
Yeah, so for the consensus document?
Yeah.
So I think I would be happy to send out an email address after the call to the people who are on the webinar that they can email to sign on. It would basically be to contact Clifton Garman at Vocal, New York, with funds. And not always that effective to spell out the email address, but it's Clifton, CLIFTON, at vocal, VOCL-NY.org, O-R-G. So if you email Clifton with your sign-on to the consensus statement, the Hepatitis C elimination consensus statement, he will add you to the consensus statement document. I really want to kind of make sure to close, for those who are still on the line, with really trying to take some time to visualize concrete next steps that you can take within your organization, and also really try to visualize the toll that this epidemic will have if we allow it to continue, both for the younger generation who we're now seeing rises in new hepatitis C infections, and for baby boomers, many of whom have been living with hepatitis C for many years and are starting to see the negative consequences. This epidemic, it will have tremendous toll in terms of death and also and other consequences, health consequences for people. We always talk about the need to cure HIV or have a cure for HIV. This is an epidemic we do have a cure for. It should be, it should really be a call to action for everyone to be part of this fight, especially if you're on a webinar like this, to actually do something and be part of the solution. I know that doctors have to take a Hippocratic Oath, you know, or the modern version of that. And I know that part of that entails preventing disease when possible and curing disease when possible. And I emphasize that this is a place where it might not be the patient in your office at that moment who has Hep C, but we need to put the policies in place and get the resources to identify those people and get them to you. And that's the problem we're having now, and we need your help. So I really emphasize every single person to activate and be part of this work.
Definitely. Thanks for that, Reed, and thank you to HepCure for hosting this webinar. And we got our emails at the beginning of the webinar slides, and these are great questions that still sharing with the group. We're happy to talk offline about it. So have a great day, everybody. And
care. Thanks, Reed and Mike, for your time and your presentation. To our listeners, thank you for attending the HepCure teleeducation webinar this afternoon. We hope you will join us for our HepCure ELF co-sponsored webinar next Tuesday when Dr. Eiteman will be presenting on controversies in hepatitis C therapy. As a reminder, a brief survey about the HepCure webinar series will pop up when you exit today's webinar. If you can, please take the time to fill out our survey, as it will help us improve the series for you. Until next Tuesday, have a wonderful week. Take care, everybody. Be safe.